Femoral neck fracture can occur as a result of low energy trauma, as in the elderly, and in this case you need to get medical consultation. It also can occur from a high energy, as in falls or motor vehicle accidents. It can occur in the old and in the young, and in this case you need to apply the ATLS protocol. Also, femoral neck fracture can occur from insufficiency fracture because of weak bone, because of osteoporosis or osteopenia. The patient will have groin pain, pain with axial compression. The X-ray may be normal, can be helpful in diagnosing the insufficiency fracture. You can also have a stress fracture due to overuse and more loading on the hips. It can happen in athletes, in ballet dancers, in military recruits. The classification can be anatomic classification. You can have the subcapital fracture, which is common, or the transcervical fracture and the basicervical fracture. Subcapital fracture has two famous classifications, the Gardner classification and the Powell's classification. We start with the Gardner's classification. It classifies the fractures according to the amount or the degree of displacement. It really relates the amount of displacement to the risk of vascular disruption. This classification applies to the geriatric and insufficiency fractures. They classify the fracture into two groups, in non-displaced type 1 and type 2, and displaced type 3 and type 4. Type 1, incomplete fracture and impacted in valgus. Type 2, the fracture is complete and non-displaced on at least two planes, the AP and the lateral. Type 3, the fracture is complete and partially displaced. The trabecular pattern of the femoral head does not line up with the acetabular trabecular pattern. In type 4, the fracture is completely displaced with no continuity between the proximal and the distal fragments, and the trabecular pattern of the femoral head remains parallel with the acetabulum trabecular pattern. Powell's classification. There are three fracture types within the Powell's fracture classification. It classifies the fracture according to the orientation and the direction of the fracture line across the femoral neck. It relates to the biomechanical stability. The more vertical the fracture, the more shear forces and the more complication rate. Type 1 have an obliquity less than 30 degrees. Type 2 has an obliquity from 30 to 50 degrees. Type 3 has an obliquity between 50 to 70 degrees or more. As the fracture progresses from type 1 to type 3, the obliquity of the fracture line increases. The fracture line becomes more vertical. The shear forces increase, and the instability increases. Horizontal fractures are good and stable. Vertical fractures are bad and unstable. The more displaced the fracture, the more disruption of the blood supply and the chance of avascular necrosis and non-union, which can occur in about 25% of displaced fractures. If a non-union occurs in a young patient, you may help the patient by doing subtrochanteric osteotomy to reorient the fracture line from vertical to horizontal. That will help the fracture healing. Another area of interest is the femoral neck fractures associated with femoral shaft fractures. The typical neck fracture is vertical and non-displaced. It may require internal rotation view X-rays to see that fracture. This fracture can be missed. The treatment of these associated fractures is to fix the femoral neck fracture first, followed by femoral shaft fracture. The usual combination is parallel screws in the neck and retrograde femoral rod for the fracture femur. Another interesting fracture is type 3 Pipkin fracture. So you will have fracture of the femoral head plus dislocation of the hip plus fracture of the femoral neck. Try to avoid reduction of the hip dislocation by closed means. You may want to do an open reduction of the hip dislocation, especially if the femoral neck fracture is not displaced. Stress fractures. It's more common in females due to the female athlete triad. It can be tension fractures. A fracture or a callus is present on the superior aspect of the femoral neck. We know adult bone is weak in tension, so we will fix that. We need to fix that. No question about it. In fact, it should be an emergency operation before the fracture displaces. In compression fractures, the fracture or callus is present on the inferior aspect of the femoral neck. Some people say if the fracture is less than 50% across the neck, the fracture could be stable and you can do protected crutch ambulation. And if the fracture is more than 50% across the neck, then the fracture is unstable and you will do ORIF. Some people fix all stress fractures of the femoral neck. A female runner and groin pain is a stress fracture. Get an MRI and you probably have to fix the fracture. Femoral neck fracture fixation. Anatomy. The neck shaft angle is approximately 130 degrees. The anteversion is approximately 10 degrees. There is no periosteum in the neck, no abundant callus, and the fracture heals by industrial proliferation. The medial femoral circumflex artery is the most important blood supply to the femoral head. It is the lateral epiphyseal artery. In young patients, the injury is usually high energy that may lead to a vascular necrosis. Some believe surgery should be urgent in the young to decompress the compressed vessels. The more displaced the fracture and the more vertical the fracture, the more likely the risk of complication will occur, including disruption of the retinacular vessels, vascular necrosis, and non-union. Femoral neck reduction should be anatomic, either by a closed technique or open technique if closed technique failed. Ulcer is an area of stress transfers. It is a posteromedial dense plate of bone. It forms an internal strut within the inferior part of the femoral neck and the intertrochanteric area. The mechanism of injury. Low-energy fracture occurs in the elderly from a fall into the greater trochanter. The fall in the elderly is different than a fall in the young. Wrist fractures occurs in younger group than the hip. Wrist fractures followed by spine fractures followed by hip fractures. So the young will try to protect themselves by falling on the wrist. High energy fractures occur in both the young and the elderly from a fall or a car accident. A stress fracture can occur in athletes. Insufficiency fracture occur in the elderly, and it is usually an occult fracture. History. Obtain adequate history from the patient, such as any syncopal episodes and loss of consciousness. The pre-injury ambulatory status may determine the treatment selected for the patient. Falls and low sodium will increase the risk of hip fractures. Clinical exam. Position of the leg is usually shortening and external rotation. X-rays. You will get an AP view and a cross-table lateral view. In cross-table lateral, you move the uninjured hip away, so the one that you move is the normal hip. It is better than frog leg lateral. You may consider traction internal view if the fracture is comminuted. You may also look for hip arthritis or pathological fracture. If you have a comminuted femoral shaft fracture, you may look for an associated femoral neck fracture by getting an AP internal view of the hip to look for that occult fracture of the femoral neck. CT scan. It's important when you have a non-displaced femoral fracture of the neck and comminuted femoral shaft fracture. You may see the fracture in abdomen pelvis CT scan cuts, usually before surgery. MRI, good for occult and for stress fractures. If the patient cannot bear weight, get an MRI. If there is contraindication to an MRI, get a CT scan or bone scan. Bone scan increases sensitivity by waiting 24 to 72 hours after the injury. The 1-year mortality is 30%. The risk factors for mortality will include surgery delay more than 4 days. This may double the mortality rate. Probably these patients are sicker than the average patient. Any patient with comorbidities more than 4, that will increase the mortality. Renal patients with hip fractures are a problem. Institutionalized patients and patients that may have low sodium will have a high risk of mortality. Surgical timing. The optimal time for surgery is after medical stabilization. There is an improved outcome if surgery is done within 48 hours. Surgical delay up to 72 hours for medical stabilization warranted in patients that are not healthy. Surgical urgency of fixing the fracture in young patients may be important. Surgery. Displacement and physiological age of the patient will decide the treatment. Non-displaced fracture should be fixed to prevent displacement. You will do it for the young and for the old. It is a minimal surgery. Screws are placed in an inverted triangular pattern with inferior screws posterior to the midline and adjacent to the calcar. If the fracture is displaced and the patient is young, you do closed reduction or open reduction to have the fracture anatomic. The fracture should be anatomic. Avoid malreduction. Adequacy of reduction is the most important factor. A healed femoral neck fracture with shortening is associated with a poor functional outcome. Open reduction of the fracture. You can use a Smith-Peterson approach. It is the anterior approach, and it is between the sartorius and the tensor fascia lata. The lateral cutaneous nerve of the thigh can be injured in this approach. Or you can use Watson-Jones approach between the tensor fascia lata and the gluteus medius. The superior gluteal nerve may be injured if the dissection is more than 5 cm above the acetabulum. In general, the sooner the fixation, the better the result. When we talk about screws for femoral neck fracture, we're talking about 3 parallel cancellous screws. The screws should be inserted 5 mm from the articular cartilage. The inferior one will be within 3 mm of the cortex, and the posterior ones will be within 3 mm of the cortex. Avoid posterior superior position of the screws to avoid injury to the blood supply of the head. Inferior and posterior screws are better. The screw threads should cross the fracture site. Try to insert them above the lesser trochanter to avoid fracture below the fixation. If the neck is comminuted, add a fourth screw. The basicervical fracture will be fixed by hip screw and anti-rotation screw. Displaced fracture in an active elderly patient will be treated by a total hip replacement because you will have better function, but you will have also more dislocations. It's also used in patients with degenerative arthritis or rheumatoid arthritis and femoral neck fractures. Displaced fracture in the elderly and the patient is debilitated, you will do bipolar or unipolar. What approaches will you use? Posterior approach will have more dislocations. Anterolateral approach will have gluteal muscle weakness, or you can use the anterior approach. An older patient with a displaced fracture and a screw fixation, it's considered a minimal surgery, but there is an increased risk of secondary surgery, 40%, so don't do it. How about the surgery for non-union? You can use the valgus intertrochanteric osteotomy. That will change the orientation of the fracture from vertical, which is biomechanically bad, to horizontal, which is biomechanically good. Intertrochanteric hip fractures, it occurs in the region between the greater and the lesser trochanters of the proximal femur. It is approximately 50% of all proximal femur fractures. The neck is about 40%. There are important trabecular patterns at the proximal femur, and it occurs according to the Wolff law, response of the bone to stress. There is a primary tensile trabecularly, and there is a primary compression trabecularly. Also, there are secondary tensile and compression trabecularly. In between them, there is the word triangle, which is a weak area. The tensile forces can create microfractures or stress fractures at the superior neck in response to the repeated load. There are some important points related to fractures of the proximal femur, especially in the elderly. One is the DVT, which can occur in about 80% of patients. Patient will need chemical and mechanical prophylaxis. The duration and the type of the prophylaxis is not determined. There is no unanimity for it. Get the patient out of bed and weight bearing as tolerated. The patient will auto-regulate their ambulation. Another important point, some of the patients may have delay before they come to the hospital. So they might be in the floor for many hours, maybe even days. So check them for DVT, for ulcers, for dehydration, for malnutrition. They can be very sick. Probably you need go medical management with the medical team, and you will try to do surgery early within 48 hours because this is associated with decreased 1-year mortality. If the patient have ASA 3 and 4, that will increase the mortality, means they are medically complicated. That will increase the mortality. The whole concept of treatment of hip fractures is you want to control the impaction and collapse of the fracture, and you want to restore the alignment. There are 3 types: stable, unstable, and reverse oblique. Or you can divide them into regular intertrochanteric fracture and reverse oblique. And the regular pattern will be either stable or unstable. Occasionally, the intertrochanteric fracture extends into the subtrochanteric area, and that is usually considered subtrochanteric fracture. So let's take the stable. You will treat that by a sliding hip compression screw. You will insert the screw center, both in AP and lateral. In the elderly patient with severe osteoporosis, it's preferred to put the screw inferiorly and posteriorly, definitely not anteriorly and superiorly. The tip apex distance should be less than 25 millimeters, both in the AP and lateral x-rays. When the tip apex distance was greater than 25 millimeters, it led to fixation failure. You can see how we measure that. In stable fractures, 2-hole may be better than 4-hole plate. This compression hip screw should not be used in reverse oblique fractures. Always look for the integrity of the lateral femoral cortex. How about the unstable fracture? That is based on loss of the integrity of the posteromedial cortex, which acts as a buttress against fracture collapse. In this case, the ability of the fracture to resist compressive loads is gone, is not there. So the fracture could collapse into varus and retroversion. In this case, we prefer to use a rod. It will avoid fracture collapse and medial displacement of the fracture. It is a percutaneous technique. Complication of the rod can be fracture at the tip in short rods or perforation of the anterior cortex in long rods due to mismatch between the bow of the femur and the bow of the rod. Also, a screw cut out. How about a sliding compression hip screw and side plate for this type? It's an easy, but it may cause medial displacement of the shaft. If you're going to use it, you got to use it with caution. How about the reverse oblique fracture? It's an unstable fracture pattern. The lateral cortex is not intact. You cannot control the compression with a sliding hip screw. Because of the fracture lateral cortex, it will not support that. Therefore, the fracture will slide. Some people consider it a subtrochanteric fracture, so you can use a rod, blade plate, dynamic condylar screw, or proximal femoral locking plate. Do not use a sliding hip screw. It can lead to major displacement, non-union, and hardware failure. Fracture through the lateral cortex is a predictor for reoperation if you use the compression hip screw. Lesser trochanter fracture, isolated. If it is avulsion in adolescence, it's probably due to avulsion of the iliopsoas. However, in an old person, rule out pathological metastatic fracture. So what are the complications of intertrochanteric hip fracture? The most important complication is implant failure. It usually occurs in the first 3 months. The failure is about 60% if the tip apex distance is more than 45 millimeters. The tip apex distance is important. Also, if you use dynamic compression hip screw in reverse oblique, that probably will fail. What other treatment you give the patient? Check the patient for osteoporosis. You may need to start the patient on calcium and vitamin D and weight bearing as tolerated because the patient autoprotect or autoregulate. And it is controversial. Some people like toe touch.